welcome back to Thrive Alive. I am your host, Nurse Jazmine, and today I have some very special guests for you. I am talking with Valerie and Darwanna. They are nurses and they work at Rush and they work with the Family Connects program. We will get into what that is in just a moment, but I do want to break the ice a little bit. I have a question for both of you. How did you know that you wanted to be a nurse? Please talk about your educational background. I'll start with you, Valerie.
Sure, and thank you so much, Jazmine, for welcoming us onto your platform. I knew that I wanted to be a nurse because I actually worked in business and government first, and I had the pleasure of working for the state of Illinois. So I saw a lot of different community members' needs, and a lot of those needs were involving healthcare. So at that time, I decided that I wanted to really have more of an impact and really go to where community members needed more assistance. And so I chose nursing. And I actually graduated from the gym program here at Rush.
Awesome. Thank you so much for that introduction. Miss Darwanna.
Thank you, Jazmine, for having us. Well, my journey with nursing started in 3rd grade, actually.
Wow.
We had career day at school,
Okay.
and one of the parents who was a registered nurse told us about her journey to becoming a nurse, and I was captivated. So I was inspired to become a registered nurse after hearing her story, and I went on, finished high school here at Whitney Young, shout out to the Dolphins, and then I attended Southern Illinois University in Edwardsville. SIUE. Are you a Cougar too?
Yes.
Yes.
Yes. Wait a minute.
Yes.
Wait, we got to pause for 1 second. Because every time I tell somebody I went to SIUE, they be like,
Carbondale.
yeah, what is SIUE? Carbondale? I'm like, no,
Yes,
Edwardsville. Oh my goodness. Yes.
Fangirl moment.
I love that.
My people. Okay.
Okay. That just like excited my soul. Okay. All right. We're gonna keep the conversation going because we could talk for 30
All
minutes
day.
about that. Okay. Please describe your role in the maternal child healthcare space. How did you come to occupy this role?
So with Family Connects, I have been working with Family Connects for about 2 years. And I have always worked in community. So I love being a community health nurse. I love public health. And I've always really had an affinity towards maternal infant health. And so the opportunity presented itself with the Family Connects position here at Rush. And I decided to transition into that. Something about just maternal health in general is such a beautiful time. We know that it can be amazing and filled with a lot of positive energy, but it also can be very challenging. And so it's really an area that I was like, I really want to dive into that and be able to help families during a very special moment. So when the opportunity presented itself, I definitely was and still am very grateful to be a part of the Family Connects team here at Rush.
Awesome.
Nice.
Awesome.
So I also work with Valerie as a community health nurse, and I actually started my career here at Rush on the inpatient side. Okay. So I worked in the NICU for a few years, and then my desire to go into lactation and help with breastfeeding caused me to want to be in more of a healthier baby setting. So I went ahead and transitioned to maternal newborn. So I was on the mother baby unit, and I started seeing changes in the healthcare system. I started seeing changes in workflow, and 18 years into my career, I actually started noticing that patients were going home sooner. They weren't staying in a hospital as long. So I had a question of like, what happens to our patients when they leave? There were less opportunity to do education, less opportunity to just give that information to the family. So when I heard of Family Connects, I was all in. I said, this is the job for me. Let's bring it into the living room.
She said, let's bring it into the living room. I love that. Awesome. Awesome. So speaking of Family Connects, you guys have mentioned a couple of times. I would like for you to describe the Family Connects program. What evidence led to the development of this initiative? Why is it important? What kinds of support, and I'll repeat these questions. What kinds of support does Family Connects provide for new parents in Chicago? So just tell me a little bit about what Family Connects is and why is it important? Why is this something that we need for new moms?
Absolutely. So Family Connects is actually it's an international organization. So FCI is what sometimes people will see when they look up Family Connects. But it was started back in 2008, and it actually comes out of Durham, North Carolina.
Okay.
So that was kind of the initial setting. It was a partnership with Duke University.
Okay.
And from that time, so in 2009 and then again in 2014, there were randomized control trials that were happening. And as we know, when it comes to research that is top tier, that's the gold standard of what you want to look at as far as evidence-based and how, this model came to be. And so it was basically a pilot program that started with that partnership with Duke University. And so from those controlled trials, they were able to see that families who participated in the program versus families who did not were able to see less incidents of going to the emergency room for visits. There was more bonding with family, more just receptive behavior to the infant. We do a lot of education about families understanding that you cannot spoil an infant, right? So it's okay to hold your baby. And there was also less incidence of families having intervention from like Child Protective Services. And so there are a number of things which I'd be happy to speak with you about as far as what we actually do in the home that is helping to prevent some of these negative things, and also at the same time increasing those positive behaviors. So even going through everything from safe sleep to understanding medical emergencies, both for the infant and for the mother. But the overall thing or the takeaway about Family Connects is that we know that you really cannot separate social needs from physical and mental health needs. And so this program really looks at the holistic picture of what a family who has a newborn at home is needing. So we're able to go into the home, assess for those needs. If someone is having issues about housing, they may not really be interested in learning about peak crying and what's going on with their baby, because at that time their priority is to find a home. And so when we're there, we can assist with those things. So that's really what we do, is kind of we're able to be in the home and take that holistic view and seeing what the patient needs, and not just leaving it there, but then actually working with a team. We definitely do not do this alone. Working with community partners, working with the great resources that we have as a big medical center, and also with the Chicago Department of Public Health, who really oversees the whole Family Connects program in Chicago.
Okay. Wow. Thank you. That's awesome. Let's just take a moment I just want to take a moment and applaud you guys, because
thank you.
Meeting people where they are is how you get stuff done. Like you said, if mom don't know where her and baby is going to lay their head at night, how can she focus on the other needs of the baby, or you know what I mean?
Exactly.
Food, housing, these are your basic needs. If you don't have that, you can't even function.
Exactly.
Right.
So, wow. I'm just amazed, because this is my first time hearing about Family Connects, and I've been at Rush for a year, but I work, you know, we talked about this earlier. Working in Rush is huge.
Yeah.
Right.
It's no way to know about all of the different things. So I just love learning about what people are doing in the community. It's so important.
And we're so happy that you allowed us to be here and just really spreading the word about the program.
Absolutely.
Definitely.
Absolutely.
And some of the things that we do, we offer lactation support in the home. We help moms with breastfeeding in those earlier days, earlier weeks, when it can be a struggle. And I tell my patients, if it was easy, I wouldn't have a job. So that gives some insight to how it can be challenging. And just care for the baby, care for the birthing parent, and we care for the whole family. So it's not just the couplet, it's the entire family. So we help with lactation, we help with some material needs. Sometimes it's difficult to learn about safe sleep if you don't have a crib for the baby. So we help provide material resources like cribs, car seats, baby clothes, formula, diapers, you name it. If we don't have it, we're going to find it. So we help with transportation. Sometimes a barrier is just having transportation. It means to get back and forth to a doctor's appointment. So we have services for that, and just help with navigating the healthcare system. Sometimes a parent may not know when to follow up for the OB appointment, or when to follow up for the baby, or what are the emergency signs to look for? When should I call the doctor? So just helping navigate those things. That's what we do.
Yes, absolutely. And you don't know when you get discharged, you worried about getting home. You know, it's very overwhelming. You get a whole lot of information given to you at one time. So it's just really important to have someone there with you to help you digest everything. You know, once the dust settles and you're home with this brand new human, to have that support for someone to just help you, you know, kind of walk you through what's next, you know. So, wow, that's great. Okay. You guys kind of answered all of those questions. So I'm going to go ahead to the next question. I want to talk about postpartum depression. What is postpartum depression? How is it different than postpartum blues and postpartum psychosis?
So postpartum depression essentially is depression after having a baby. It can present with certain symptoms. They look like low mood, lack of sleep, or just lack of sleep for days on end. Sometimes you just don't have the desire to take care of yourself, don't have the desire to take care of the baby. You may have a lack of appetite, trouble bonding with the baby as well. And postpartum baby blues is what I like to call depression light. It's more so a temporary form of those symptoms. It usually resolves in about a week or two. And it's not self-limiting. So you'll have the low mood. You may not have the appetite. You may not have the drive for bonding with the baby, but you still can do activities. You can still care for the baby. You can still be motivated to take a shower. So when it comes into postpartum depression, that is longer. It can last months or even longer than that. So postpartum psychosis is more of an extreme psychiatric emergency. It's almost what you see on the news. It's when a patient actually loses touch with reality. It can present as hallucinations, sometimes suicidal ideas, suicidal thoughts, homicidal thoughts on harming the baby, actually. No one asks for it, but it has no respect of person. It can show up if it's your first baby or your fifth baby. If you have a support system or you're by yourself, it just can happen. So it's unfortunate, but it's those extreme cases that we see, unfortunately.
Wow. So it's important to look out for those symptoms that you said. You know, if mom is having a hard time becoming attached to the baby, or, you know, neglecting her needs or the baby's needs, that's something that, you know, we can be on the lookout for.
Exactly.
And thank you for explaining the difference, because I think it's hard to differentiate the three terms, you know, because most moms get baby blues, you know, but not every mom falls into postpartum depression. Not every mom falls into postpartum psychosis. So it's good to know the difference, and as a support system to know what to look out for. Okay. That was heavy.
Yes.
Okay. But we needed to talk about that.
Those are things we need to talk about.
Absolutely.
And many times, especially in our culture, we don't discuss those things. A lot of times things have to be prayed about, or you have to, reach into your spiritual life to really work through. And sometimes God gives you healthcare providers to even see that spiritual realm again.
Yes.
Sometimes those days can be very dark. So we have to be able to see those signs. And I usually like to tell the whole family about those signs, because your family or your partner may see signs in the birthing parent that they didn't even notice. So it's essential just to have that awareness amongst everybody, the entire family, and be able to intervene early.
Absolutely. It takes a village, right?
Definitely.
Absolutely. And it's definitely the same. I just, what Darwanna said is so true. And the thing is, you can have a lot of things helping someone. So it's great to have that spiritual relationship and pray about things, and also talk to a counselor.
Absolutely.
And so a lot of times, family and friends, partners, they want to know, well, what can I do to help? When everyone has a baby shower and they're so excited and they're bringing everything, I like to think of that time as like, great, so we're excited. But then once the baby comes home, still have that same energy into looking into the family and seeing, what's happening. If there are changes that are either physical or mental, the physical ones, we can kind of like, okay, you're saying that you're having a headache. This has been going on for some time. It's excruciating. That we want to make sure that now you seek some medical attention about that in the postpartum period. The same with if someone just cannot do those regular activities, like Darwanna said, you're not bathing, if days are going on, or someone is like just really kind of almost refusing to bond with the baby. If that's going on, though, that's a sign that maybe there needs to be some intervention here, some help provided. And so it's not the mother's fault. It's no one's fault. There's a lot of chemical changes that are happening in the body. And so there's no shame in this. It's about, how is someone feeling physically and emotionally, and then being able to provide those connections in that time to be able to help the person bridge through and really recover from whether it's physical or mental.
Absolutely. I have one more question for you guys. It's very, very important that we talk about this, especially for our community. You guys mentioned earlier during the pilot study, you saw a difference in intervention needing to happen as far as like at a state level, or as far as like extreme measures. Can you talk about that and why it's important to prevent that? Because I know, as an African American, growing up as an African American, I know how my family didn't want people in the home. You know what I mean? We don't want, that's our sacred, safe space. So why is it so important that we're there to prevent actions like that?
That's a really great question. And the first thing that I can say, something that's big about our program, is integrity. And so when we are even talking to the patient for the first time, it is important that we are able to build trust. And when they allow us to come into their home, we take that seriously. And so that is a real fear for some families. A really great thing about our team is that we are diverse. I love that we do have different cultures represented on our team.
That's important.
And so when it comes to the Black families, just historically, we know that kind of fear of having outsiders come into the home, especially knowing that healthcare providers are mandated reporters and things of that nature. It's a big big gift for someone to give us that trust to say, yes, you could come in.
Absolutely. Absolutely.
And so sometimes there are needs for intervention that a family may already be dealing with. Mm-hmm. So let's say before they had an open case with Child Protective Services or DCFS here, in Illinois, if that was happening, then those situations, we do need to take, more care. We talk about that actually during the visit.
Okay.
That's one of the questions that we ask about. And so whether something was founded or not founded, most of the time, when those cases are open, there is some type of plan that needs to be in place. Mm-hmm. So it could be someone who is dealing with a challenge with substance use. Mm-hmm. It could be for some type of neglect to a previous child. And there may be a concern from, an official body, from the government. In those cases, with the parent and the family being a part of Family Connects, that is actually a good sign for them, because that can be a part of that plan. If they would need counseling for any reason, sometimes that's mandated. But if a family says, okay, yes, we'll do this voluntarily, that is a good in the eyes of, those bodies for protective services. That is a good thing for them to have. And so to even preventing those things from happening, we want to make sure, as Darwanna said, that if there are tangible things that a family needs, we can provide them with that. If there's concerns that a baby is staying in a diaper for hours on end, right? Does the family have diapers?
Right.
Can they change that baby? Are they making, if they're using formula, are they making the formula correctly, or are they trying to stretch it because they don't have the monies? These things this is real life, and it happens. And unfortunately, if a baby is, kept in a diaper for too long, or if they're not getting the proper nutrients, that is a bad situation for that baby, for that family. And so we want to be able to come in and assess that, and then be able to provide those tangible things that can stop those negative situations from occurring.
Absolutely.
So we know that, some people might already be connected to like state services. They may not be connected. And if they're not, we can help with that. But on the spot at that time, we can help them with giving them diapers. There's different other community partners that can help them later on with delivering items to their home. So they don't even have to go anywhere to get it. They will come and deliver these things to their home at a later time, so that we can help and continue to find them ways to be able to sustain that. One pack of diapers is not going to solve the problem, right? But then being able to connect people with services. So if someone is not signed up for the WIC program, but they're eligible and they have chosen to use formula, we want to make sure that we can do that. Let's get you an appointment, make sure that you know where your local office is, and get those things happening. So we know that it can be some devastating situations occurring for lack of just not having the tangible needs. And so that's something that we really hold very dear, that we are able to step in and provide those things, and then provide the sustainability for that family.
Absolutely. Thank you so much. That was such a great explanation. And I really, really want to hone in on the word you said, sustainability, because it's one thing to, place the items in the home, and then couple of weeks go by, then what? So just having the connections that you all have, and building that bridging that gap for the family, so that they can, continue to sustain raising their family.
Yeah, exactly.
Did you have anything to add?
Sure. Well, what we do is we bridge the family to the community. So many of our resources are already built in place in the city of Chicago. So we want to make sure our patients are aware that they exist and have access to them. Many times unfortunately, in the healthcare system, we will call a patient non-compliant. And we are able to come into the home, and many times our families let us in to have a better understanding of those social determinants of health, those economic barriers that don't allow for compliance. It may not just be a situation, I didn't check my blood pressure. Well, if I don't have a blood pressure monitor, maybe I cannot do that.
Right.
And if a baby is living or sleeping in an unsafe situation or an unsafe environment, was a crib accessible? You know, so sometimes we can ask the questions or see the spaces and be able to say, hey, let's see if we could prevent some of these things. Let's prevent an unsafe sleeping environment for the baby by helping you get a crib. Let's avoid a baby not being able to have the vital nutrients by helping you with breastfeeding or helping you have access to that food that you and your family may need. So a lot of times we're honored that our families at least open the door and feel comfortable with us coming through. And not only do we see a problem, we do something about it. Because it's no point in seeing something and just being like, well, it's checked off the list.
Right.
What are we going to do about it?
Right. Absolutely.
So we want to be solution oriented.
Yes, absolutely. You guys have talked so much about the Family Connects program. I have a question. How can a family that has just delivered get involved with the Family Connects program?
Yes, so we are so pleased that Family Connects is at 7 hospitals right now in Chicago. And so we hope to have all birthing hospitals in Chicago on board with the program. But overall, Family Connects is just kind of supervised by the Chicago Department of Public Health. So they really look at, all of the hospitals and invite people to come on board. And right now we're, of course, here at Rush. We are at Mount Sinai, University of Chicago, Roseland Community Hospital, St. Anthony Hospital, Humboldt Park Health, and also Swedish Hospital. So Family Connects is a universal program in that any family who delivers at any of those hospitals and also lives in the city of Chicago is eligible for the program. We have no income eligibility requirements. There's no particular zip codes. We will see any family that would like to be a part of the program. And so where the equity comes in, because that's something that's really important to our model, each family is, assessed, and we look for ways that we can help. Some families need more than others. Some families need tangible resources. Some families may want assistance with information about having anxiety in the postpartum period. It's different for every family. But as the nurses and as our whole team, we really have that place and that honor to be able to assess what's needed and then provide equity in those moments to really fill in where the family needs it.
Absolutely. Well, I know if you guys showed up at my door, come on in. You guys are just lovely, and you're so passionate about what you do. And I personally appreciate what you all are doing for the community. We have done a series of episodes centered around Black maternal health. And we're just trying to let the community know what is available for them. So you guys have done an amazing job explaining Family Connects, heavy on the family.
Family.
So thank you guys so much. It's been a pleasure having you. And
thank you for having us, Jazmine, and Thrive Alive.
All right. Dr. Cavenagh, thank you so much for joining us on Thrive Alive. We are so happy to have you. I am excited to learn more about your expertise. So we are going to jump right in. First question, again, I want to break the ice. I want the community to get to know you a little bit better. How did you know that you wanted to be a nurse? Please talk about your educational background.
Thank you so much for the invitation, Jazmine. I really appreciate being able to share my story. So my journey through nursing has been, I kind of feel like it's been, the universe has just been leading me in this direction. You know, nursing found me. I didn't go into nursing because I always wanted to be a nurse. I was always interested in science. I actually thought about medical school for a little while, but I didn't want to spend the time and the money. And you know, as I started thinking about what fits, someone mentioned nursing, and I looked into it, and I thought that seems like a good fit for me. Nursing is we've always talked about the art and science of nursing, right? And I love the science part. I always knew the science would be something I was attracted to, but I really, really love the art part, which is the caring part and the actual personal touching, you know, like touching a person's life part, being in the room with them at the most critical times of their lives. And that really, really, I'm a person who likes to get under the skin and likes to get to that deeper level. So that really appeals to me. I really love I feel privileged to have to be able to be present in people's lives during the most critical times, you know, happy or sad. But yeah, so that's why I chose nursing as a profession. And truthfully, my career has just blossomed as I've been 37 years in it now. And I cannot think of a better career. I have had, you know, so many different opportunities and so many, I've worn many different hats over the 37 years. And I just feel like, you know, it's been a wonderful journey.
Awesome.
Yeah.
Awesome. It's just something about a nurse.
Yes. Yes. We are special people. I think so.
Yes.
Yeah.
Wow. Thank you for sharing that with us. So I'm going to ask you a little bit about your role. Please describe your role in the maternal child healthcare space. How did you come to occupy this role?
Yeah. So I started out knowing in nursing school that I was interested in labor and delivery.
Okay.
I really, really enjoyed being there at a person's, you know, the most joyful time in their life, experiencing that with the family. So I knew I wanted to do that when I got out of nursing school, but there were no jobs in labor and delivery at the time. So I ended up, quite by accident, I ended up in NICU, neonatal intensive care, which was right next door. So I figured I would learn the baby part and then maybe transfer over to labor and delivery. But it turns out I ended up at NICU and just loved it. So I stayed there for 14 years.
Wow.
I did end up doing some work in labor and delivery after, but what I loved so much about NICU was not just caring for the babies, but your patient really was the family. You know, it was the baby, but you can't really talk to the baby. So you're spending all of your time talking to the family. And so what I realized in that experience was that I really, really loved education. I loved seeing the light bulb go on over someone's head, you know, explaining to them what was happening and having them ask questions and looking up the answers and being able to explain that. So that's what really, I got involved in maternal child care because I was talking to moms all the time and I was helping them care for their babies. And I was, you know, able to point them to resources and direct them to, you know, ways to take care of themselves and their babies better. So that's kind of how I got interested in it and just kind of developed from there. I like to be a reflective person. I think that, you know, I try to teach this to my students, and you know, I've tried to practice this myself at various points in your career when you start to feel a little like you need a shift, you need a change. Like sit back and reflect a little bit on what sparks joy, right? What about what you're doing is the joyful part, and then move in that direction. So when I realized I really loved teaching the moms, I'm like, well, how can I be a teacher? Like, you know, what takes me in that direction? So interestingly enough, I didn't mean to take the journey I took. Everything kind of happened by accident, but I was looking for something in education. So I started looking like what is out there. I didn't want to go back to graduate school because I had 3 little kids at the time. And I found a program at NIU at Northern Illinois that was a graduate certificate in health education. And I thought, it's 5 classes. It's doable as a, you know, in the time of my life that I was in. So I signed up, and there were 5 classes on health education. I thought maybe I would just work as a health educator. And I found that I loved it, and I loved being back in school. It was so, you know, learning something new. And so I got done with those 5 classes, and luckily I had an advisor at NIU who said, she encouraged me. She said, you know what, you seem to really like this. She goes, you are halfway through your master's in public health. Why don't you just get the rest of it?
Might as well. You halfway
just get
there.
the rest of it, right? So I was like, okay, you know what? I could do that. So that opened up a door that I had absolutely I had no idea about public health. I
Wow.
ended up by accident in an MPH program, and that opened up a whole area of healthcare that was brand new to me, and that was the bigger picture of healthcare. So I mean, so far I'd had the clinical experience of the direct care of the baby and the education of the parent, but the MPH really opened up a whole other sphere, which was the larger problems surrounding healthcare and the reasons why people find themselves with poor health outcomes. And so that MPH really, really led me to think bigger picture. But I still had the interest in maternal child health. So I ended up, long story short, I ended up that opened some doors for me to have a different role in nursing. So I was able to have a higher level role as a clinical nurse educator at West Suburban Hospital in Oak Park,
I was born there.
Were you? Yeah, yeah. I live in Oak Park, and so those of you who aren't familiar with Oak Park is on the west, just across the street from the west side of the city, and Oak Park is a very high resourced, very affluent area, and the west side of the city has a lot less resources. So we see both sides of the spectrum, like right across the street from each other.
Right.
So the unique part about West Sub is that you get both sides. You get to see both the Oak Park residents and the West Side residents. And so I was able to marry my interest in maternal child health with my interest in public health right in that place, and see people with resources and what they experienced, and people who didn't have as many resources and what they experienced. So that was that's kind of how I got my maternal child interest, and how I married the public health and the maternal child at the same time.
Awesome. What an amazing story.
Thank you.
You just kind of it's like you floated in a river and you just ended up.
That's how I feel. That's how I feel. A friend of mine recently told me that, she kind of takes life as like she's on a raft, and it's wherever the river is going, you just kind of let it, but you have to be kind of intentional along the way too, and take time to stop and think about what will my next step be, and how can I do that with integrity?
Absolutely.
Yeah.
Awesome.
Yeah.
Thank you for sharing.
Thank you.
Awesome. Okay, so I want to get into a very important question. I am just dying to ask you. First of all, there is a Black maternal health crisis that we're experiencing right now in this country. And my question to you is, how can the medical community prepare the next generation of maternal health care providers to respond to this crisis?
Yes, there is definitely a crisis, and this is one of it's interesting. I got interested in this. I became aware of this, the extent of this crisis, while I was doing my doctoral program at Loyola. I was preparing to do a final project in 2018, and exactly at the time that I was thinking about what I wanted to do, of course, it was going to be in maternal child health at something. But that was when the first maternal mortality and morbidity report was released from IDPH, in Illinois Department of Public Health. And I read the report and I thought, oh my God, at the time in 2018, the report was that Black women were 3 times more likely to die of a pregnancy-related condition. In Chicago, they were 6 times more likely to die than a white woman. And I thought, wow, what is going on here? And we need to address this problem. Right. So that's how I got interested in it. The timing, again, it just felt like the universe, here's the report, I need a project. Okay, well, that's what I'll be doing. So that's where I started learning about it. And it really is. It's a crisis. There are lots of levels of issues that relate to this crisis. There are issues at the individual level, issues at the community level, issues at societal level, and it's not until I think we start to think about making changes and on all of these levels that we can start to make any kind of real impact in that. Right. So I do think that, remind me of the second part of your question.
How can the medical community prepare the next generation of maternal health care providers? So the people that are in medical school and nursing school right
Exactly.
now,
Right.
you know, coming into this.
Yes. I think the most important thing is for them to understand all the different levels of influence, right? So because in the medical community, we typically, we respond to the individual level, right? We're going to talk to you. We're going to tell you what you should do, right? And I took a health coaching class when I was doing my doctorate to prepare for my program. And one of my favorite lines was, she goes, "We got to stop shoulding all over people." Yeah. You know, we got to stop telling people what they should do,
Right.
and start thinking about what they can
What
do.
they can do.
And what they're able to
Absolutely.
do because of the resources they have or don't have, right?
Absolutely.
So we have to recognize at an individual level, yes, there are things you can do at an individual level. You can pay attention to your health prior to getting pregnant. You can pay attention to your health while you're pregnant. But unfortunately, if you don't have the resources to do that, that's the community level problem, right? Then we have to prepare our medical professionals to understand there are other influences. There are community influences, and then there are governmental influences that can either help or hurt a person's ability to take care of themselves. So I think what we can do as preparing the next generation of medical providers is help them understand these different levels and recognize that, we've mentioned that we've called patients non-compliant in the past, but get rid of that language. It's not about compliance. It's not about, everybody wants to be healthy, right? Everybody wants to have a healthy child. They're not choosing to do this. It's what's in place for them to be able to do that.
Right.
So we need to be able to really make the social determinants of health part of our regular conversation and say, what can we put in place societally, community, and individually to help you have better health outcomes?
Absolutely.
Yeah.
Wow. Thank you so much for breaking that down. I like that term. What did you say? We should people too much.
Stop shoulding all over people.
Stop shoulding all over people. I like that.
I know, that was my favorite line.
That.
Yeah.
Because it's true.
We do it a lot. You should do this. You should eat this. You should do that. Right? You should exercise. Well, if there's no place to safely go exercise, then I can't. Right? You should eat healthy food. Well, if there's no place to get it, then I can.
Right.
Right? If I can't afford it, then I can.
Right.
So
yeah. So we have to look at the bigger bigger picture.
Exactly.
Absolutely. Okay. What role, if any, speaking of different levels, right? What role, if any, do you think the government has in responding to this crisis?
Yeah, it's a good question. We try to teach our nurses. So I teach at Rush in the General Entry Masters program, which are clinical nurse leaders. And we try to teach them about advocacy because that's a big part of the nurse's role as well. And it's not just advocating for your patient individually in the hospital when they're there. It's also advocating for rights and advocating for social justice rights and advocating for government to get involved. And, going to Springfield and talking about getting bills passed that will change the trajectory of someone's health outcome. So the government plays a huge role in that. We've seen how public health wins or public health successes have happened over the years when the government's gotten involved. So one of them is seatbelts, right? When we were younger, nobody had seatbelts in their cars, right? And then I remember when we first started instituting seatbelts, and you remember the electric ones that would automatically buckle you in, and they would make people mad because they didn't want to wear the seatbelts, right? But that was kind of like a government intervention, and now it's illegal to not wear a seatbelt. So guess what? Everybody's wearing seatbelts, right? And that's so we have better health outcomes. We've also seen it with smoking, where smoking is the government involvement makes it easier to make the right choice, right? Because if you're in a non-smoking place, then you have to inconvenience yourself to go outside and smoke. So I think, the government's role is, if laws are passed because they recognize that this benefits the population, then it just makes it easier for people to make the right choice.
Right.
And makes things more accessible. So the two things that I'm proud of Illinois about are that back in 2018, the number one cause of maternal mortality was hemorrhage, which is bleeding, right? And so what I saw in action was pretty amazing. The response to that crisis was that the government got involved, and especially in Illinois and in California, other states, they mandated a postpartum hemorrhage education for every single person that took care of an obstetric patient, even down to the housekeepers.
Wow.
Yeah. So anybody who walked into that room had to take this education. And what I saw happen in front of my eyes was that we had such a much more coordinated, response to hemorrhage that it was, I mean, it was amazing to see just what could happen from that kind of mandate, right? We had to educate everybody. We had to have things put in place to respond more quickly, to assess a patient for hemorrhage to begin with, and then respond more quickly. And the result was that we went from 17%, which was the rate of maternal mortality related to hemorrhage, down to 5%.
Wow.
Since then. So it shows that swift, decisive action taken by a local government or even state or national government can really make a difference. And the other thing Illinois did, so Illinois did that in 2019. They instituted that, and since then we've had a much better approach to hemorrhage. And the other thing they did was just last year they passed a bill that expands Medicaid coverage for postpartum women to 12 months. Which is huge.
That's huge.
It's huge because a lot of people don't know that the mortality rate, the pregnancy-related death rate, a lot of that happens in the postpartum period, right? And it doesn't just happen in the 6 weeks. It happens up to a year postpartum. So to extend those benefits to a year is massive, because that means that women have access to care for longer during that critical postpartum time. And it also provides coverage for doula services and for Family Connects or home visiting programs like Family Connects, which means they have access to services to help them through that really critical time. So if the government gets involved, it allows us to, or it gives us the resources we need to provide the care that we need. And it provides some sustainability as well, because, there are private organizations that'll stop in and Family Connects is actually, at Rush is actually very well supported by a private organization as well, but those funds dry up, and those funds don't necessarily, they're not necessarily sustainable. So when the government gets involved, it provides kind of a line item in the budget to be able to support these things on an ongoing way.
Right.
Yeah.
Can I ask you another question?
Sure.
That's not on my sheet. Can I just ask you to talk a little bit more about the postpartum period? Because you mentioned that women are having poor outcomes up to a year after delivery. So can you just kind of talk about what is postpartum?
Sure. Yeah.
Like, we think, it's right after you have the baby, up to 6 weeks, you go to your checkup appointment and that's it. But it's actually much further than that.
Absolutely. So to talk about postpartum, we have to talk about prepartum.
Okay.
So let's just talk about pregnancy in general, right? I think women do not have an appreciation for the magic that has to happen to create a human being.
Right.
We don't know. We don't have a true appreciation for all of the changes that have to happen in your body to make a positive outcome, right? So your body has got to adjust to massive changes to grow a human being. You've got your blood volume increases by 50%, which is a lot more pressure and stress on your heart, right? You have your blood sugar levels have got to change to feed this baby. You're feeding a whole human being and it's growing, right? You've got all of these nutritional needs. You've got hormonal changes that have to happen. Your blood vessels have to be able to relax to accommodate that extra blood. All of these changes have to happen, and they only happen, I shouldn't say they only happen, they happen in any environment, but they happen best in a healthy environment. So if you're not healthy before you get pregnant, then your body is already compromised and it's not going to make these changes well. So what we're seeing is a lot of women are having poor outcomes because of the pre-pregnancy state. They start with 43% of all mortality, pregnancy-related mortality rates are related to have obesity or as a precursor.
43%.
43%.
Wow.
Or hypertension, or diabetes, or some chronic conditions before they get pregnant that put their body in a compromised state. So then when they're pregnant, they can't make those necessary changes to accommodate that pregnancy well. So that's first of all, that's one of the main changes is pre-pregnancy and during pregnancy. And then postpartum, when the baby's out, right, then our attention goes to the baby, right, naturally. We start thinking about the magic that has to happen in our body to reverse all those changes, right? So now your heart, you've lost all this, or you're losing all this blood volume. Your heart's got to make that accommodation. It's got to change again, right? Your blood vessels have to reaccommodate. Your hormones are changing constantly. You're bleeding. You've lost a lot of blood volume through bleeding. You're breastfeeding or not. You're exposing now yourself to infection through breastfeeding possibly, or through, the delivery process or a C-section scar. There's all of these things that women's bodies are adjusting to and adapting to after pregnancy that we don't tend to pay enough attention to, right? We kind of feel like our bodies are magic. It will do it, but what we're seeing is it's not doing it necessarily to the best of its ability because we're not paying attention, right? So the postpartum period is, yes, the most critical part is certainly within the first 6 weeks, and that's when we typically send our visitors out, to visit the home. Actually, the American College of Obstetrics and Gynecology, we call it ACOG, they just revised their standards to say that their first postpartum visit it used to be 6 weeks, it should be 3 weeks, right? We should be seeing our patients sooner and following up according to their needs. So not just at a regular 3 weeks, 6 weeks, whatever, but according to what they need. Because some women come in more compromised or have different complications from their delivery experience or their pregnancy experience. So, so at 6 weeks for sure is critical, but then what we're not, most women don't realize is that up until that year after having a baby, that is, your body is still making those adjustments. You're still in that postpartum period. And so even though, they may get through the 6 weeks and they're totally fine, they still may have things that they're experiencing that are pregnancy related up to that year. So that's why it's super important to pay attention to signs and up until a year. And when you're seeing your doctor, whenever you see a doctor in any situation, if you go to the emergency room, if you're in a car accident, if any reason you come in touch with a doctor within that 12 months, you should let the doctor know I had a baby, within this past year, because it may relate to the symptoms that they're seeing.
Wow.
Yeah.
Awesome. Thank you so much for breaking that down and explaining that so well. And thank you for explaining the different changes that goes on with your body, because I don't think
we don't appreciate it.
And we don't even realize it.
We don't realize it. And if we did, I think we'd have such a better appreciation for just the magic of it all.
Yes.
Yeah.
Absolutely.
Yeah.
Dr. Cavenagh, you talked about the postpartum period being a very crucial period as far as positive versus negative outcomes. Can you talk to me about some of the symptoms we should watch out for during that period?
Absolutely, yes. So this is not something that I think we talk about enough in healthcare, and I think part of the reason is we don't want to scare new moms, right? So we don't want to tell them all the bad things that could happen. But the worst part of that is that they go home and they don't know what to look for.
Right.
And a lot of times women are feeling a lot of symptoms that they just attribute to, well, of course I just had a baby, of course I have a headache, of course I'm tired, of course this, right?
Right.
So there are our professional organization, the Association of Women's Obstetrics and Neonatal Nursing, came up with an acronym. It's called POSTBIRTH, POSTBIRTH.
Okay.
And these are the acronym stands for the symptoms and signs that you should look for that are dangerous or warning signs after pregnancy. So I have them written here because I'm not going to remember them off the top of my head. But P is pain in the chest. Anytime you have chest pain. Anytime you have chest pain, it should be checked out, right? And not ignored. But because of all the changes that happen cardiovascular and with your heart during pregnancy, it's especially important that if you have chest pain, not to ignore it. Just go check it out. Just, which is why you need access to a doctor, of course, but don't ignore it. Don't just, pass it off as gas or something. It's your heart is going through a lot of changes. So definitely take note. These are actually 911. The first four, the POST or 911. If this is severe, if you're experiencing this, you should call 911.
Okay.
The second one, the O, is obstructed breathing or shortness of breath.
Okay.
And that's more than shortness of breath on like when you're walking or exerting yourself. That's normal. But if you feel like you can't catch your breath or like you're taking deep breaths or you feel like you're not oxygenating for some reason, that's something to check out.
Okay.
You could have an embolism or some kind of a postpartum complication that's obstructing your breathing in your lungs. All right, so then the S in post is seizures.
Okay.
That's obviously 911 emergency. If anybody notices you having a seizure, you're not going to notice yourself having a seizure probably, but call immediately for help. That could be a sign of a very important danger sign. And then thoughts, T is thoughts of hurting yourself or the baby. And this leads back to the postpartum depression or psychosis that we talked about earlier, which is if you really, really have thoughts that, you're going to hurt yourself or possibly hurt your baby, that's also an emergency. And that we need to follow up on that immediately. Other signs, the BIRTH signs, these are not necessarily 911 emergency signs, but call your healthcare provider and follow up.
Okay.
The bleeding. So we want to pay attention to how much every woman bleeds after they have a baby. And they don't necessarily know how much is normal, right? So if you're bleeding more, if you're filling a pad more than 1 pad an hour, that's too much.
Okay.
Or if you're passing blood clots, the size of an egg or bigger, that's considered to be too much as well. Okay. So that's something to just follow up, let your doctor know, say I'm experiencing this, and they can keep track, because that's part of the hemorrhage or the overbleeding issue that can lead to bad outcomes. An incision, I, is if an incision's not healing. So if you had a C-section or if you had an episiotomy and it's not healing, or you're noticing either redness or swelling or pain, extra pain, or drainage or anything like that from the site, then that needs to be followed up, because that could be a sign of infection.
Okay.
Redness or a swollen leg that's painful or warm to the touch. Women don't really know, like, I had the baby here. Why should I care about what my leg? Of course, maybe I stretched my leg wrong, or maybe it was, when I was pushing or something. But typically, this could be a sign of a blood clot, and your blood is changing. Your hormones are changing. The consistency of your blood is changing as you're recovering. So it is not uncommon for some women to have a blood clot, and sometimes it lodges in the back of the knee or in the leg, and that would lead to warmth, pain, especially, it doesn't typically happen in both legs at the same time. So if you're feeling it especially on one side or the other, that's a sign that maybe there's something lodging there. And the danger with a blood clot is that it doesn't always stay where it is. It can cut off circulation to your leg, of course, but it can also move. It can transfer, it can move in your blood and then end up someplace vital, like your lungs or your brain. So we're concerned about that. Temperature of 100.4 or higher. If you have a temperature, that's also your body's sign of a possible infection. So if it's 100.4 or more, it should be checked out. And then headaches. This is one that is easily missed. A lot of women miss this sign because, again, they're tired, they lost some blood, they're maybe not eating right, they're up all night. Of course, they have a headache, but a headache that is persistent, that doesn't go away, that doesn't get better after taking medications, that's something to be checked out, because that could be a sign of hypertension or high blood pressure.
Okay.
And a headache with visual changes, especially, like if you're seeing blurry vision or spots, definitely check it out, because that could be a sign of high blood pressure.
Okay.
And if not taken care of, that's what can lead to a seizure. So it's important to know. I mean, like, we know we shouldn't have high blood pressure, but why? Like, what does it do to the body, right? It could end up bursting blood vessels in your brain and causing a seizure or a stroke. So those are the understanding the why, like, I'm having these symptoms, but why? Why is my leg important to my right? Why is my headache important? Why are all that stuff? Understanding that all of these symptoms, they may or may not relate to the pregnancy experience and the postpartum experience. So being aware of what these are, and actually having your family members be aware of them too. That's huge.
Yeah,
right?
Absolutely.
Yeah,
absolutely.
So having what I know, this organization, they have little magnets that they create with post-birth on it that people can stick on their fridge. They don't want to we don't want to scare women, but we do want to make them aware.
Yes.
Right.
Yes.
So those are the danger signs.
Okay. Thank you so much for sharing that. And yes, it is very important that not only we know the signs, but we know why.
Exactly.
So that's so good. Post-birth. Okay. It is permanently ingrained in my mind.
Yes. Yeah.
Well, Dr. Cavenagh, it's been a pleasure having you on Thrive Alive. Thank you so much for sharing your expertise. Thank you so much for sharing your background with us. And I'm just excited for the people to learn more about how to be healthy moms, healthy people, right?
Yeah, absolutely. Wonderful. Yes. Thank you. Thank you so much.
Thank you.